are about to start our next session. And we are a little bit behind schedule, so again, please turn off your mobiles, and we would like to welcome you for the next session, which topic is after 10 years with systemic sclerosis, what can I expect? And it is my pleasure to introduce my co-chair, who is Paulo Clemente Coelho, who is a rheumatologist at the Portuguese Institute of Rheumatology in Lisbon. He is the coordinator of the systemic sclerosis and capillaroscopy units.
Many thanks for the introduction, and I want to thank FESCA for the invitation to be present here. And we will deal with a very important issue, a very important and practical issue, because in my view, the diagnosis of systemic sclerosis not as a death sentence, but as a partner, and a partner to live a long life with the most better quality as possible. So it will be a pleasure to be here. And I will introduce the first speaker. The first speaker is Dr. Jason Lee, who works with Professor Janet Pope in the University of Ontario, Canada, in the field of internal medicine and rheumatology. He is now getting a PhD in vascular medicine, and he is dedicated to the investigation of systemic sclerosis. Dr. Lee will talk about predicting the future in systemic sclerosis. Please, Dr. Lee.
Thank you very much for that introduction. Pointer works, perfect. So first off, I'd like to thank the organizers again for having me, and again, thanks to Dr. Janet Pope for sharing her slides with me so that I could share them with you today. Is this working? Okay, perfect. So I'll be talking to you today about predicting the future, which when I first heard that that was the title of the talk, I was a little bit overwhelmed because it's a bit of a challenge to predict the future. Over the next 20 minutes, hopefully I'll stay on time today, unlike yesterday, but I'll talk to you about what happens in long-standing scleroderma beyond 10 years and sort of give you an idea about what to expect as time goes on. As I said earlier, I was a little bit daunted by the task of predicting the future, and the first image that came to my mind was a crystal ball. But obviously, I don't have a crystal ball, and I can't exactly predict the future. So what I'm hoping to do is give you some of the science instead of a crystal ball as to what we know about the disease and what you can expect going forward. So as we talked about yesterday, systemic sclerosis or scleroderma has many symptoms, and sometimes when you first get diagnosed with scleroderma, it's kind of like looking at a subway map that's on the bottom here. The top subway map is the subway map in Toronto, and it's very simple. It only goes in one direction, a big U, and if that was your disease, you wouldn't need me to tell you how to predict your future, because there's only one way to go. But scleroderma is a multi-system disease that's very complex, and when you get first diagnosed, it's very overwhelming. So hopefully I can guide you through this complicated map and make it more like this top map rather than the bottom map. So this is kind of a general rule of thumb in scleroderma that Dr. Pope has published a few years ago, and it's called the 15% rule in scleroderma. First off, whether you have the limited subtype or the diffuse subtype, which we'll talk about, almost all patients with scleroderma have Raynaud's phenomenon and swallowing issues from acid reflux. That's relatively universal. But of the people who have Raynaud's phenomenon, 15% of you in this room will currently have an ulcer at the fingertips, and 15% of those fingertip ulcers will become complicated with either ischemia or infections. Also, going down the list, you could see 15% will eventually develop pulmonary hypertension, which we'll get into in more detail, and 15% of you will have some fibrosis or scarring in your lungs that may make you more. Again, 15% will develop arthritis at some point, and also myopathy or muscle disease that'll make it more painful or difficult to move around. Sjogren's syndrome is dry eyes and dry mouth, which doesn't sound significant, but actually it's a huge issue, especially with dental hygiene, and it gets into issues with painful when you're eating and drinking water, so that it is a serious issue that requires multi-allied health teams. And then especially in patients with diffuse scleroderma, but it can happen in limited of renal crisis, so we'll get into that. But if you take away nothing else, remember the 15% rule in scleroderma. So to get into more specifics, in order to figure out what your disease is going to look like 10, 15 years from now, to know what your scleroderma looks like. And the current classification in the scientific literature deals with the limited subtype and the diffuse subtype. The definition of skin involvement, so you could see in the bottom right-hand picture in this slide, limited simply means scleroderma that affects the skin, distal or past the elbows and below the knees. If you have any skin fibrosis or skin thickening above the elbows or above the knees, then that's classified as a diffuse subtype. The reason why that's important to know, as we'll get into in more detail, is that depending on your subtype of disease, it'll impact what your risk of developing organ dysfunction will be down the road. So I'll start off with the skin thickness. Everyone here is familiar with this picture where you have either puffiness in your fingers and hands, or you have thickening that make it difficult to open your hands or stretch your fingers all the way. Inflammation, as you can see in this picture, is characterized by thickening and puffiness, but also redness. So I don't know if you can appreciate in this picture, but there's redness, and that's indicative of active inflammation. And if you were able to feel this hand, it would feel warm, and warmth is a characteristic of inflammation, which is an early finding of skin disease in scleroderma. Eventually, that inflammation causes more scarring and more thickening, and this picture represents what can happen when the thickening becomes severe and late. So this with contractures and even more difficulty opening your hands. So prediction number one, or what we know from the literature, is that depending on your subtype, either diffuse or limited, will tell you about your skin involvement. So if you are the bottom line, which is a limited subtype, where your skin fibrosis is just past the elbow and nothing above the elbows, over the course of your disease, your skin fibrosis will be most in the first 5 years and then kind of level off after that, but there's not a lot of regression without treatment. So this graph, I should preface by saying that this is the natural course of disease, so this doesn't have anything to do with treatment response. If you're the diffuse subtype of scleroderma, what you'll notice is that you'll have all of your fibrosis or skin thickening in the first 5 years of disease and probably closer to the first 3 years of disease. So that's where all of your skin thickening and inflammation is going to happen. After the first 5 years, you actually start getting a spontaneous improvement in your skin thickening, and some of you who've had the disease for a long time may have noticed that. So even without any treatment, your skin thickening after the first 5 years tends to improve. And then besides the skin findings, which are relatively common and uniform between the two subtypes, there's also the blood vessel changes in scleroderma, and we talked about this yesterday with Raynaud's phenomenon, and if those are severe, you can get the fingertip ulcers. In terms of the vascular symptoms in scleroderma, what you'll find is that the Raynaud's phenomenon becomes more frequent and oftentimes harder to treat as you get on in the years. So medications may not work as well in your 15th and 20th year of disease than your first 5 or 10 years. Also, you'll notice that the red spots, either in your hands or in your face, called telangiectasias, may get worse over time, and you may get more in number. But the telangiectasias are not dangerous in and of themselves, so you'll just notice it's more of a cosmetic effect. So next we talk about the organ involvement, because at the end of the day, that's what impacts your quality of life most, at least in the literature. Again, this is where the classification between limited subtype and the diffuse subtype comes into play. If your disease is more the limited subtype, you're less likely to have kidney involvement and you're less likely to develop renal crisis. You're also less likely to have lung fibrosis, but later in the disease, you're more likely to get pulmonary hypertension or high blood pressures in your lungs. If you're the diffuse subtype, you actually have a lower chance of having pulmonary hypertension, but you're at a higher risk of developing renal crisis or high blood pressures that could be life-threatening. Also, with the diffuse subtype, you're more likely to get lung fibrosis, making you feel breathless. But again, pulmonary hypertension is less prominent compared to the limited. In terms of the timing of your organ involvement, if you're the diffuse subtype, just like the skin, all of your organ involvement is going to happen within the first 5 years of disease. After that initial 5 years, your organ involvement is what it is. You're probably not going to get more organ involvement. So after the 5 years of disease, what you have is what you're going to get. On the other hand, in the limited subtype, the organ involvement progresses over time. So the pulmonary hypertension tends to happen later in disease as you get older, rather than early in disease that follows a skin progression. In terms of what we know from the data, in the 60s and 70s and even the 80s, scleroderma renal crisis used to be the #1 cause of death in patients with scleroderma. But fortunately, that's not the case anymore because it's very treatable and we know how to prevent it, or treat it rather. The main causes of death in scleroderma now is pulmonary hypertension and pulmonary fibrosis, so screening becomes an important factor. We talked about this briefly yesterday, about screening for pulmonary hypertension, but this involves echocardiogram or ultrasound of the heart to look at the pressures in your lungs, and also pulmonary function tests to see how well oxygen passes from your lungs into your bloodstream, which has an impact on your overall survival. So this is a quick slide from the US showing that the lungs' ability to pass oxygen from the lungs into the bloodstream is an important factor in your long-term survival. One additional factor in your lung health that's been it's been developing in the literature is your risk of developing blood clots. So the first article here, Dr. Pope and I published 2 years ago, the increased risk of developing blood clots either in your legs or in your lungs with any inflammation disease. And then just this past February, just this month actually, the group in British Columbia and Canada looked at specifically patients with scleroderma, and there appears to be a slightly higher risk of blood clots in your legs and in your lungs as well. So there are other factors that can affect your heart and lungs that you need to watch out for with your healthcare team. You may have noticed that your healthcare team or the presenters don't talk about scleroderma renal crisis as much as it used to, or they used to. And the reason, like I said, is because the incidence or the risk is going down over time. That risk is going down over time because there's a good treatment for it, but it doesn't mean that we can ignore it. Because if you're at a higher risk with the diffuse subtype, you still have to have that in the back of your mind because it can be life-threatening. So sometimes people ask, do I not have to worry about this anymore because it doesn't seem to be as big a risk as it was 20 years ago? And the answer is no, you still have to be mindful of it. It's just that it's more treatable, but if you're not looking for it, then it'll be too late, and that's where you run into trouble. We talked about this briefly yesterday as well, but not all patients with scleroderma experience the disease in the same way. So like we said yesterday, you need to self-educate, and I'm glad that all of you are here to learn about the disease in more detail, but you need to learn about it so that you can personalize your treatment to your own disease. Other organ systems that we didn't get the chance to talk about today include arthritis and muscle disease. You could have a lot of GI or gastrointestinal, stomach, intestine issues, as many of you probably have experienced. And even the risk of heart disease outside of scleroderma, like heart attacks and strokes, are increased in patients with scleroderma. So it's not just the disease, you have to be mindful of your whole health, as I'm sure you are. So just to summarize, what we talked about was understanding the disease and where to start. And typically that starts with you understanding whether you're the limited or the diffuse subtype, because that'll impact on what you're at risk for. And then in general, there's that 15% rule in scleroderma, where 15% of you are likely to develop complications. And then we talked about how to screen for diseases like pulmonary hypertension and talking to your healthcare team about being mindful of these things. And then my last slide is kind of like the crystal ball. So because the talk was on predicting the future, this is my one guess at what the prediction or the future is going to be. The blue line is a trend of ankylosing spondylitis from 1950 to 2015. So ankylosing spondylitis is another autoimmune arthritis disorder that used to be severely disabling, much like scleroderma, but nowadays it's very treatable with biologic medications. I'd like to think that this curve in scleroderma looks kind of like the beginning curve of ankylosing spondylitis here. So if you think that this curve in scleroderma is like the early curve in ankylosing spondylitis, then we're just at the point where we're about to explode with new information and treatment, and hopefully that'll come within the next few years for us. So that's it.
Thank you, Dr. Lee, for an excellent and clear presentation. We will make the discussion at the end of the session.
And now I would like to introduce the next speaker, who is Kim Fligelstone. And she is a person with scleroderma who has long waged war against both the disease, not to mention the bureaucratic system that frustrates many patients. She works at the Royal Free Hospital in London, in England, and she is on our side. So, thank you, Kim.
Thank you. Thanks, Annalise, for that. I thought we were going to do questions, so I've got a question next time, if that's okay. Okay, 10 years on, and a long life with systemic sclerosis. I'm cheating a little bit because I'm way over the 10-year mark. I'm 27/28 years. But I found those Dr. Lee's slides really interesting because it really followed the pattern of what happened to me, which I'll come on to in a minute. I had a very, the diffuse form of scleroderma, systemic sclerosis. And at the beginning, it was so full on, it would be easier to tell you what I could do than what I couldn't do, because my mobility was really impaired. I felt ill, but I didn't know what that meant. I thought, I was 29, I thought, is this what happens when we get to 30? I really, really honestly thought that. Because 30 was old then. Now it seems really young. Anyway, I was quite badly disabled. I was in a wheelchair for some time, and I had the renal crisis that a certain percentage of people with diffuse. I also had the right antibodies. So it was in the days, fortunately, when they had discovered ACE inhibitors. So I'm here and very lucky to be, very happy to be here. But I did end up on dialysis, on kidney replacement therapy for a number of years. I think also, I'm not sure if you mentioned this, but I think the chances of someone with diffuse disease, the chances go down of a renal crisis. I think it's within the first 4 years, 4 or 5 years. So if you're over maybe 6 years and you've got diffuse, then you can relax. But also just take your blood pressure if you're before that. Okay, I've lost myself. So I had my renal crisis and was on dialysis, and I lost an incredible amount of weight, which is hard to believe looking at me now, but I went down to 37 kilos and I had no muscles. And I think that's why I was in the wheelchair, because I couldn't stand up for myself. I thought I looked lovely. I looked in the mirror and I saw this gorgeous, thin person, but I probably didn't see quite how thin I was. Anyway, I was very pleased. I mean, it took me about 10 years to go up to 60 kilos. But I was actually quite pleased that they didn't weigh me to get on the plane, because I would be way over 60 kilos. I don't want to know what I weigh now. So that was all good. I mean, I don't want to point a completely rosy picture. I developed calcinosis quite late in the disease, so maybe in my 24th/6th year. And I know it's not as bad as some people had it, but for me it was very debilitating. My fingers were very bad, and especially my thumbs. And I honestly never realized until I couldn't use my thumbs how difficult it was. I think in the early stages I couldn't use my hands at all because the skin was very tight, and that has, 5,000 times improved. But when I couldn't use my thumbs because of the calcinosis and the pain, I really had to start again and think, it's like they're our tools. They're the tools that you use in the garden. That's how you eat. That's how you dress. And I couldn't do all those things again. And that was like 24 years afterwards. I'm pleased to say that has improved considerably. You can see I can move everything and I'm not wearing bandages. You can see a little bit of Raynaud's because I'm nervous. I do also find things like receding gums. I hate that. I mean, it's great now. I can go to the dentist and I can open my mouth wide, which I couldn't do to begin with. But my teeth, our teeth seem to show a lot. And it's funny how many doctors think that my gums are big. But it's not that they're big, it's just that my teeth show more. And the gums recede. It's a bit like losing the soft tissue, I think, on the base of our feet and fingers. And I really, really, really want to make a plea, if there's any doctors here, please look into soft tissue damage, because, it affects us in every daily life in different forms. I don't think that's in my brief, sorry. Right, so I'm still improving. My mobility and my flexibility is so much better. I don't take any immunosuppressants, which I took in the early years, and they were experimental because it was 28 years ago. Excuse me. My pain is a lot better. And as I already mentioned, my mouth is really good to open for the dentist and to eat. But my lips have gone. Where have they gone? Another improvement is I don't feel that tiredness that I felt in the earlier years. So, okay, maybe I get tired now because I'm the age that I am, but it's not that real fatigue that lots of people mention when they first are diagnosed. Okay, so in the beginning, when I was first ill, I'd wake up, I'd go to work, I'd come home, I'd go to bed. And that continued every day until the weekend. And then I'd just stay in bed. And then when I was too ill to go to work, I was too ill. I remember very well how the simplest task of just getting dressed was really, really hard. And now it's simple. Preparing a meal. Everything that was getting in and out of the car. Walking down a corridor in a hospital, because those corridors in hospitals are so long. I don't understand why, but they just go on and on and on. And I can do that without even thinking about it. So, is that my time? Yeah. Good. Okay, I'm finishing. Coming to the Congress, so I'm changing now. I'm better. And I just want to say how wonderful I think these congresses are, because I think they empower us in some way to meet head on. You know, we might hear things here that we don't want to hear, but they're not necessarily going to happen to us. And if they do, we deal with them. And we can build up a network of friends. That I come here and I meet new people, and I meet people that I've known in the last X amount of years since FESCA has been going. And I'm sure that's helped me, you know, just by meeting other people and not burying my head in the sand, which I'm sure I did in the earlier years. And I think that's all I'm going to say. And just thanks for coming and listening. And I hope to see you all in 2 years' time.
So we are a little bit out of time, but we have time to one or two short questions.
Has any research been done into incidences of how common dementia is in scleroderma?
So the question was on the incidence of dementia in scleroderma, and that's an excellent question. I had another person ask a similar question yesterday about the incidence of Alzheimer's or dementia. Pardon? Oh. So I would say that there isn't necessarily a clear link between scleroderma and dementia. I would say sometimes other things that can come from scleroderma, like depression, for example, can look like dementia. So if you're having some symptoms that make you wonder, then it would be a good idea to see your healthcare team or your doctor about it so that they could determine whether it's truly dementia or if it's something else treatable like depression, for example. But I would say that the link between scleroderma and dementia isn't there now, but people are looking into it because they know that some people with scleroderma do have it.
Okay. Another question.
Ms. Fligelstone, what exactly did you mean when you said that if there are doctors in the audience, then can you please focus on soft tissue? Can you expand on that, please?
If somebody is doing research, so for a research project. Oh, okay. So why is it? Why do our gums recede? Why do our teeth stick out? Why do we lose the soft tissue on the palms of our feet? So it's so painful to walk. It's like walking on pebbles. Heads can change shape because of I'm guessing it's soft tissue damage. I'm not a doctor, so maybe I'm wrong. But why is that? And if we found out why, perhaps we can reverse it. Or do we know how to reverse it already? Because I'd love to know. Do we?
Well, it's all part of the same disease spectrum, which the people on the panel would be glad to answer, and we could always talk after the session is over. But at least if that is an area which has not been addressed by rheumatologists as far as patients' pains are concerned, then maybe we need to focus on that more and try and relieve the pain first, because it's the entire disease spectrum anyway.
Absolutely, and I've been involved in a project to find the top 10 dimensions that are important to patients. And it never came up that soft tissue damage was an issue. What did come up was mobility. But, it's such a huge subject. So I'm just making a plea.
I have another question.
I'll just make a quick comment on that. So it is part of the disease process, the tissue atrophy and the soft tissue loss that you have in your fingertips and in the bottom of your toes. It's all part of the loss of fat tissue and the scarring that you get. Unfortunately, right now, there isn't a process to reverse that, but there is research ongoing because it's all part of the skin fibrosis and fibrosis of the lungs. So that anti-fibrosis research is ongoing, and I think there are medications in trial, not clinical trial in humans, but animals so far, which will hopefully give us some answers. But this is kind of like what I was talking about yesterday with symptoms that you can't measure. You can't necessarily measure how painful it is to walk without that soft tissue under your feet, but that's where I think that gap could be cared for by patients themselves. If you have a solution like a padding that's worked for you, then that's where a support group or a federation like this can be helpful.
Can I just say, there's a lady, a very important woman for FESCA who's here, who told me about Skechers shoes, and they're the most. Beata, are you here? She might not be here. There you go. And I can't tell you how many people have now bought these shoes because Beata told me about them, and then I've told them, because they like wearing cushions.
Right. Okay. That was. Unfortunately, we don't have time for any more questions. The future in Scleroderma is very, very interesting, and thank you, Dr. Lee, for your fine presentation. It gives hope for us patients that there might be some good things on the way. And thank you, Kim, for giving the patient side. After 10 years, she's still here, and hopefully we know that she's going to be here 28 years. So you will be here the next 28 years, that's for sure. Thank you.